So neonatal sepsis, which one would you choose? Why?
CRP is better than ESR. It is more recent than that old ESR.
Rise in CRP happens earlier than CRP. Sorry, rise in CRP happens earlier than ESR, and ESR requires more blood, and both are relatively non-specific.
See, before CRP came, we used to do micro ESR for neonatal sepsis. Now CRP has come, so that must be a little better than ESR. But what is better in CRP? So the answer is CRP becomes positive very early in the course of illness. ESR takes time. ESR is good for follow-up. So here in neonatal sepsis, you want to pick up early infection. So now, of course, neonatologists do procalcitonin. I don't know.
Does the CRP change with anemia as ESR?
Oh yes, ESR changes a lot. CRP changes even with diet. But that's a small change, I imagine. If CRP is very high, nothing will be different in interpretation. But the point is, CRP becomes positive at the end of 12 to 24 hours. ESR will take 2 to 3 days. So you want to be as early as possible picking up a possible infection. And at neonate, it's mostly an infection only, not non-infective inflammation. So CRP, right? But the CRP also will go away early, become early, so it could be a good follow-up too. Whereas for rheumatic fever, it's a slow process, no? Only ESR.
So tuberculosis, CRP or ESR?
Neither of the two. When you have a tuberculosis diagnosis, what are you looking at? Look at clinically, at the end of 4 weeks he is getting better. Forget that ESR. Okay. Because then the people will have to wait till ESR comes down to normal. How many times you are doing? But in rheumatic carditis you will do ESR. Why? You know clinically, no? He's all right. Rheumatic arthritis disappears quickly in 4 days with aspirin. Why do you do ESR? Subclinical carditis continues for a long time and you will continue aspirin for that long time. Okay, so for tuberculosis, neither of the two. Because if your diagnosis is definite, but ESR is not very high, patients will say, no, but we have heard ESR becomes weak. So these discrepancies don't do any one of the two.
So incidentally, what is the screening test for tuberculosis? Screening test. Come on. I have not asked a very difficult question.
Rajesh, when X-rays were not available, we used to do screening.
So MAN2 is no longer the screening test for tuberculosis. Screening test for tuberculosis now is chest X-ray. Okay, and no CBC ESR. So CBC ESR were put in the museum 10 years back or 15 years back, MAN2 5 years back. So now it is only chest X-ray as screening.
There is an organization called as tuberculosis finding or something. And I always get what my teacher used to say, they want to test ESR, all those things, now screening. Now there is something called, she was telling CBNet.
Yeah.
And whenever the patient has right apical infiltration, ESR is 100, he is losing weight, fever, and he says that CBNet fellow says, don't give tuberculosis, anti-tubercular. What is CBNet? Can anybody tell me?
So sir, CBNet is the cartridge-based nucleic acid amplification test. It's the name of a method. Basically, it looks for the cellular material, the organism ka part it picks up. So it picks up the DNA of the organism.
Even small number.
And in a very small number. For tuberculosis, the trade name of the test is Gene Expert or TrueNat. So in government programs, they do what is known as TrueNet. In private, they do Gene Expert. Ordinary Gene Expert can pick up 16 bacilli per ml. If there are 16 bacilli per ml of sample, Gene Expert will be positive. In Gene Expert Ultra, 111 and 16.
Yeah.
So 111 for Gene Expert, 16 for Gene Ultra. So Gene Ultra will pick up even if there are only 16 bacilli in 1 ml of the sample. There is rampant resistance to tuberculosis when you look at it on a community scale. So now WHO and all world authorities have said that diagnosis of tuberculosis has to be along with susceptibility testing, and it has to be microbiological diagnosis. So you do Gene Expert in all cases. Government is doing it free so that you prove tuberculosis unequivocally, and then send that sample for testing for drugs, so that for culture and then drugs, so that ultimately you know that who is drug resistant. So this is because of the community scenario.
And I think knowing
But it's going on. When it, I'm telling you honestly, when it was proposed 6-7 years back, I also thought it was impractical. I myself thought. But no, nobody is debating yes tuberculosis. No. There must be some communication gap. We need to prove the tuberculosis with a microbiological diagnosis. So not just saying that X-ray is suggestive, or not just saying MAN2, or not just saying ESR 100. We have to have in black and white MTB detected. That is one. And second is susceptibility.
And
Because the community is at risk.
advantage of picking up a bacteriological culture has another one, that you can test against multiple drugs. And today resistant TB, multi-resistant is also common. And the best thing that has happened recently is that even multiple resistant TB can be treated with 4 oral drugs for as short as 6 months. So now the treatment is coming up to be shorter, but with better drugs. And normally what we used to do earlier is, when our primary drugs fail, we start looking at a resistant strain. We are already late by that. I mean, he would remember that one of the girl who did extremely well on the 10th standard had a recurrence, and worst is, after primary drug, which is still 1 or 2 drugs are resistant, patient improves, and after 3 months gets worse, and when he gets worse, we lost that child. Okay, this was much before all these things had come.
This was 15-20 years back, and in fact 10-12 years back there was a widely publicized scenario where a young lady of like your and my family, could have been our wife, our daughter, had gone to Hinduja hospital to the top respiratory physician, Dr. Udwadia, and he told her, I know you have tuberculosis, but I have no drugs to treat you. Because on that day she was resistant to all the listed anti-TB drugs from our family. That day these newer drugs had not come in. This was 10 years back. So that bad is the scene of TB resistance, and it could be any one of us could be at the receiving end. So we need to be very careful about how we diagnose TB and how we treat TB.
And I think Gene Expert could be negative and the culture could be positive, or vice versa. Therefore, ideally, put a culture as well. Gene Expert results would come much early, but a culture may take time, but will ensure that you don't miss any final diagnosis. And I think 3 diseases need confirmation today. Malaria is one, typhoid is another, and TB is third. Because resistant strains are tremendously seen in the community. And I think that is worrying us. So we should not depend on Vidal test. We should not depend on even a rapid antigen test. We should have a confirmation by standard test. So, 100%.
Yes,
Today
yes.
no tuberculosis.
And sir, as Dr. Mahesh Kore said, and no, 8 years back I thought this is very impractical when first proposed by WHO. But believe me, Indian government has taken it seriously. This is working beautifully in the government setup. They are doing gene expert for everyone, they are doing culture, they are doing line probe assay, you name it. And they are giving combination FDC pills. They are doing so much about notification. There is a Nikshay website. So they've really put money and effort in it. And now we private practitioners should not mess up tuberculosis. So we must be very, very clear about
And line
tuberculosis.
probe assay requires an actual,
Live bacilli.
therefore we want a culture as well. Only gene expert won't do.
Okay. Coming
think-
back to
I think we have
What hap-
about 5 minutes now. It's past 1 o'clock. Nahi, what do you think, Kavan? Because, see, we are too passionate. So sometimes till hypoglycemia and brain stops working, we will continue. But you decide the time. And we have a PG clinic also, no? At 2 o'clock. Whatever you say.
So I think 1:30 will stop because then we need to mingle with everyone also. Yeah? Okay. So what about infection complicated by HLH? Would you do CRP or ESR? Very good. Both. Why?
Rise in the CRP and fall in the ESR, sir, because of hypofibrinogenemia.
Excellent. So HLH is characterized by hypofibrinogenemia, which will impact the ESR, and therefore this is one situation where you would do both the tests.
Rheumatologists often do both. Okay, again for the same SLE for example, there are antibodies, so CRP may be normal, ESR may be high. So I think selectively you can do both. Often selectively you neither do either of the two. But then in between you decide what is right.
Antenatal scan at 28 weeks shows a dilated ureter, abortion or continued pregnancy? Continue. Pelvis.
If it is unilateral, the other kidney is nice, it's working.
So that's the point, that you have to look at so many angles and not just go by one stray finding and jump to some
Even if
conclusion.
this baby continues and is born with large ureters, large hydronephrosis, what's the problem? Surgeon can take care of it. Isn't it? Why surgeon can't take care? Oh, surgeon will take care of it. He will implant ureter somewhere differently in the. Oh, they do all that. Where is the problem? Even with UTI, you do the same, no? Do all the tests and leave it to surgeon to correct. It's a correctable thing. So the
Yeah, so-
point is that if it's only dilated ureter and upper system is not dilated, you wait and watch and see what it is. Many times the peristaltic wave looks a dilated ureter at that time, and that may not be pathological. But the point is you need to follow it up, because if there are really a malformation right from kidney down, then the glomeruli which are developing are not developing adequate numbers. And such people, by the time they are 20, 30, first pregnancy, adolescent, they will get into a chronic renal failure. So there is a danger of missing renal dysfunction. But what you said, sir, is right. Just because you are dilated ureter, you don't rush to that, right?
Antenatal scan at 28 weeks shows absence of corpus callosum.
Anyway, corpus callosum has no cognitive function, no nothing. Who bothers?
Yes, please. Right.
Actually, corpus callosum is a very difficult diagnosis for a sonologist. You should not, yes. I tell you that USG, CT scan is different.
Absence of corpus callosum can be diagnosed at 16 to 17 weeks. There is a structure called as cavus septum pellucidum.
But I know that. But I have read this, and I have told one of the urologist's wife's son to wait and do nothing and do a report again. It's because all these embryological things do not occur at the same time. And the child was born normally. Of course, follow-up ultrasound is required. Okay. So, point is, when radiologist or ultrasonologist gives something, we don't understand. We take it as black and white. If our understanding is also not clear black and white, their also understanding is same. In fact, in one of the radiologist conference, I was asked to talk. And I made a mistake that I said, you can only talk about what the image looks like, but don't tell us what the image is. So I gave them an example that in the middle of the night, you see through your window pane some object which has apparently two legs. You say it's a human being, but if the dog is standing in two, and if the human being is kneeling down, so you don't mess up. You don't say mostly human being, that we will decide. Because when I see him barking, why do I call it human being? So I will decide that. Okay.
Okay, let's come to this case. 2-year-old child presents with high fever for 2 days, no other symptoms. On examination, irritable, no other findings. What tests would you order?
Lumbar puncture.
जोर से बोल.
Just wait for the localization of the fevers.
Wait for the localization, so don't order anything.
Madam, meningitis. You can't wait for meningitis to appear. You have to act beforehand. Okay. If you don't want to do CSF, then do MRI or CT scan.
Inconsolable.
Correct. So she is coming down to the specifics of irritability. So again, if my friend Anand would have been here, he would have asked, what are the causes of irritability in unmarried people? So causes of irritability in married people are obvious. So she is saying get into the depth of irritability. So when do you call a baby irritable? How do you define irritability in a baby? Inconsolable by caretaker. So if the primary caretaker also cannot calm the baby and baby keeps crying, that is real irritability. So she's saying get into the depth of that and then decide. So the problem here is that there is no focus so far, but it's a 2-year-old and high fever. So you need to decide whether you have time to wait or you can you'll have to look for or hunt for something.
And again, the rule is if there are more than one symptom, you must ask the sequence of appearance of symptoms. If fever and irritability appeared on the same day, it is never intracranial. because the fever, bacteremia, 24 hours, 48 hours settles there, then irritability. But fever itself causes irritability on day one, and you give paracetamol, irritability is also less. So you ask for a sequence and you ask the response to paracetamol. If the mother says, with fever, irritability goes down, intracranial is ruled out, and no meningitis starts with irritability on day one. Neonate is different. Neonate will not be irritable, he will convulse only.
So on day 4, a CBC was done. So they decided to wait. Like she said, no focus, so wait and watch carefully. So on day 4, since still there was no finding, no focus, a CBC was done which showed hemoglobin 11, platelet 2.2 and WBC 18,000 with 70% polys. So now what? What is the interpretation of these tests?
If the symptoms are still continuing and if the polymorphs are 70% of 18,000, then probably there is a bacterial infection. We don't know the focus, but we need blood culture also here.
So absolutely right, but the also one added thought is that in a 2-year-old by day 4, if it is not localized, that is also a worry for me. Okay, why is it not localized so far? So that thought starts coming up, that is it systemic inflammation and why is it not localizing on day 4? But as he said, initially you would think of infection, you would send blood culture, you would look for other focus of infection. So here CRP was 40, urine 8 to 10 pus cells, chest X-ray was done which was normal. So now what interpretation? UTI?
No localizing signs, I would consider UTI with this background.
Again, here is a clue that eosinophils are 2% in that 2 years old boy and not localizing on day 4. Maybe systemic inflammation, you can think of Kawasaki in this case.
Absolutely.
So again for UTI, I mean we have to take those statements in context. So when we read something that sometimes UTI can be with just 8 to 10 pus cells, doesn't mean each time there are 8 to 10 pus cells the probability of UTI is high. The point is this is a 2-year-old running high fever for the 4th day on symptomatic treatment only. And if this was actually UTI to begin with, then on the 4th day urine showing 8 to 10 pus cells is not really what a UTI should be. Besides, of course, the fact that why should a 2-year-old get UTI for the first time? It could have been either earlier if it was some congenital issue, things like that.
And I think point is Kawasaki typical symptoms come a little later. You want a lymph node, you want ISI, glossitis, but today Kawasaki should be suspected at the end of 3 days of fever, not even 5 days. Absolutely.
No, not till day 4. Then on this, at this stage, somebody felt whether there are doubtful meningeal signs. So they did a CSF. And the CSF shows 60 cells, all lymphos with 80 milligram protein. And a repeat CBC showed that the WBC count had jumped to 28,000 with 80% polys. So now what are we thinking? So options are upgrade antibiotic, add anti-TB drugs and review diagnosis. So any thoughts now? Yeah, I think so all of them are on the right track. So platelets are also increasing. We were already started thinking, is it non-infective inflammatory? So it was indeed.
Multi-system inflammation.
And now
You
multi-system.
had urinary pustules, you have CSF now pustules. So multi-systemic inflammatory disorder at that age is Kawasaki till proved otherwise.
Criteria or a must criteria for Kawasaki. There is a tabular column given in the Nelson. As sir told, it takes 3 days or 5 days for the symptoms to occur.
We stop here.
Yes. So, but because see, if it is Kawasaki, then we have to start IVIG. So to label as Kawasaki, I need to pinpoint and tell how many of the 5 criteria are fitting into my child. Only based on antecedent fever would not be sufficient, I feel, to label him as a Kawasaki. I would look for more evidence of Kawasaki. Because I'm just thinking, because then why there is an essential criteria given, then these are the, or you can label them as atypical Kawasaki, but only based on fever can it be called as an atypical Kawasaki.
You're right.
I feel by the end of 3 days, you are reasonably sure it's not a bacterial infection, because it would have been localized and clinically would have been apparent. When it looks like bacterial infection, but it is not, it's neither viral infection nor any other infection, it is an inflammatory disorder, non-infective. And at that age, Kawasaki stands way up amongst all systemic. So the question is, we need to counsel the parents and say that this is a gray area, whether if we wait long, there could be a damage, and therefore to prevent that possible damage, we should treat right now. And I think, yes, IVIG is costly, but the damage is far more costly. So this needs a proper counseling, because earlier days the typical definition was 5 days of fever. Now it has come down to 3 days. Because by 3 days, we should be sure it's not a bacterial infection. Right?
Yes. In a smaller children, in infant, it is difficult to diagnose Kawasaki, and they may not have all the 4 or 5 criteria that has to be satisfied by given guidelines. These are the guidelines only. We have to smell Kawasaki in a small children much earlier, as sir has said, on a 3rd day, where the high grade fever is there, irritability is there, ESR is high, CRP is high, and all the inflammation which is non-infective, we are not finding any focus on any. That's why we do CSF here to say that is acute bacterial meningitis is ruled out, because only 60 cells, all lymphocytes, almost rules out bacterial meningitis. Done a chest X-ray.
And,
Why not get a 2D screening echo done,
Yeah,
and we look for CAD, coronary artery dilatation.
Yeah.
the first time it was reasonably right to wait. Okay. But I would have got into more details. When did the irritability come? When did it get out? Okay, that would have been. But
Exactly. So 2D echo is justified, but if 2D echo is normal, it doesn't rule out Kawasaki. In fact, you are in that golden phase where you have suspected Kawasaki and you are about to prevent an aneurysm by treating it with IVIG. So therefore, lack of aneurysm on 2D echo is not ruling out Kawasaki. If you get it, you are lucky.
and I think if you have a small child like this, 1 or 2 year old, a cost of IVIG is much less. If you're looking at 10-year-old for IVIG, you will have to spend so much.
15 days back, we had a 3-month child having a high grade fever like this only, and there was no localization. We have done a CSF, we have done a X-ray, we have done a blood culture, we have done a urine culture, all negative. We have done a echo on 3rd day, but coronary was normal. We waited for 5 days, blood culture to come, urine culture to come, all tests negative. Then again repeated echo, and there was the Z score was 3.5, both the RAD and LAD. So that has given you, but coronary was normal at that point of time. I still would have given a IVIG thinking clinically incomplete Kawasaki. You can say that it is incomplete Kawasaki to be worked up further if it doesn't respond to IVIG and a low dose steroid now we give 2 milligram of methylprednisolone per day.
Urine culture were negative in this case. What happened to the cultures of blood and urine? Negative. And I think in these cases, when we are not 100% sure by criteria, we need to, as sir was suggesting, discuss with the parents, tell them the pros and cons of each methods, and then let them decide what to do, and be responsible for that.
Actually, the reason for presenting these cases is that, we tend to hang on these small abnormalities. So this particular case was being treated as UTI because of those 8 to 10 pus cells, and many days were wasted in calling it UTI. And then that CSF report came, and then another few days were wasted in that. So this is the problem, that we have to start thinking right from the beginning that something is fishy, right? Yeah. Now before we end, we just want to make a few announcements. So we have Amdekar sir's latest initiative is a YouTube channel, Steer by Dr. Amdekar team. You can click this, or even if you just type on YouTube Steer by Dr. Amdekar team, you get to the channel. So these are 10-minute videos put up every Tuesday and Friday at 7 AM on some short clinical topic. And these are not textbook topics. These are topics which make you think or which make you solidify your concepts. So there are different sections in this. We are beyond 210-15 videos now. 216th will go online, and they are all archived. So you can see right from video 1 in your free time. And there are concepts like hepatic manifestation of non-hepatic diseases, or some other role of some investigations in these diseases. So there are many such concepts which are strengthened in these videos. Then we have books, lessons from the grand rounds, which are available with JP Brothers. Steer book is also now going to be available with JP Brothers. It will be released mostly at Pedicon. We have a book called Even When There Is a Doctor by for parents. And then we have this book, What Doctors Must Learn by Amdekar sir. This was written during the COVID period, and it's again a very nice read for all young students. And finally, we have Thursday classes, which are there 6 to 8 p.m. There's a YouTube link which I will share with Kulkarni sir. This is not the YouTube link, so you can send it to the students. So you all can join live if you have time, 6 to 8 on Thursday, and then we can even indulge in similar question answer session if you are live on Zoom, right? Okay. Thank you. Thank you very much.
Dear friends, I hope you all had a wonderful time listening to the two stalwarts. So any questions, anything that doubts you have about your case at your hospital, you couldn't understand, probably they will be available for another hour or so. We would be breaking for lunch now. After that, we would have the postgraduate case discussions that will be going on. So please attend that, so to learn about how the approach to the case should be. And before that, we would like to have a group photograph with sir, with the whole team, so that we can share the photograph with you in the group. So thank you, sir. On behalf of IIP Dharwad District Branch, I would like to thank Dr. Amdekar sir as well as Dr. Rajesh Shukani sir for being here with us for the whole day and enlightening us with the talks on the whole thing about the pediatrics, the wisdom that they have gained. So thank you very much, sir.